Every major report on the future of global health in the 21st century converges on the same uncomfortable conclusion. The greatest determinant of human disease burden in the coming decades will not be a new pathogen, a metabolic epidemic, or a pharmaceutical failure. It will be the disruption of the physical environment on which human health ultimately depends. Climate change is not a future problem for medicine. It is a present one, and the healthcare community's response to it has been inadequate in proportion to what the evidence demands. The Lancet Countdown on Health and Climate Change has been documenting this trajectory in systematic annual reports since 2017. Heat-related mortality is accelerating in every region where reliable data exists. The geographic range of dengue fever has expanded dramatically northward over the past 2 decades, with transmission now recorded in parts of Europe that had no historical dengue burden. Malaria vectors are similarly migrating into higher altitudes and higher latitudes as temperature thresholds shift. These are not projections. They are observed, documented epidemiological changes that are already reshaping disease burden in regions whose healthcare systems were not designed for this pathogen profile. Heat itself is a direct cause of organ failure in ways that are both well understood and inadequately prepared for. Extreme heat events accelerate acute kidney injury, precipitate cardiovascular events, and increase mortality in elderly, pregnant, and outdoor working populations. As mean temperatures rise and heat extremes intensify in frequency and duration, the clinical volume generated by heat pathology will increase substantially in regions that include major population centers in South Asia, Sub-Saharan Africa, and parts of the Middle East that are approaching the physiological limits of human heat tolerance. The food system dimension is equally serious. Climate disruption is already affecting crop yields, nutritional density, and food distribution stability in ways that translate directly into malnutrition, micronutrient deficiency, and the metabolic consequences that follow. The relationship between food insecurity and chronic disease risk is well documented, and climate change is a primary driver of future food insecurity trajectories. What medicine has been slow to integrate is the recognition that clinical practice cannot remain reactive to these changes. Treating the patients who arrive in emergency departments during heat emergencies is necessary but insufficient. Healthcare systems need climate-resilient infrastructure, hospital cooling systems, supply chains designed for disrupted logistics, disease surveillance systems calibrated to novel vector distributions, and medical training needs to incorporate planetary health as a core competency rather than an elective curriculum addition. The uncomfortable political dimension also needs acknowledgement. Climate change is the product of energy and economic systems with enormous institutional interests in resisting the changes that would reduce its trajectory. Medicine's engagement with climate as a health issue inevitably puts healthcare institutions in political territory that many have historically avoided. That avoidance is becoming increasingly difficult to justify when the clinical data is this clear, and the cost of continued institutional silence is measurable in patient deaths. The health consequences of climate change are not speculative. They are here. They are worsening, and medicine needs to say so with the same clarity it applies to any other well-documented cause of premature mortality.